Hi, I'm Lauren Meffin, speech language pathologist, owner and operator of Wildflower Therapy. Today we are going to review a fiberoptic swallowing study and a clip of the swallowing study and sort of discuss the movement of the epiglottis. Okay, let's get to it. So I'm going to start off by playing our fiberoptic swallowing study. So what we're looking at is we have a camera in the patient's nose, and the camera is looking straight down into their throat. We are just over the back of the tongue or the base of the tongue, and we are looking at the epiglottis. Now that epiglottis, you can see, is kind of shape-wise what we would call blebbed or omega shaped, right? And depending on your training and your speech pathologist who taught you this, as we look into this, we have a beautiful view of the laryngeal vestibule and the upper airway. Now, one of the things I'm noticing right off the bat is at rest, my patient is really working a little bit harder than I would probably prefer to have that sort of resting coordination. So we're getting a lot of movement of our arytenoids. And so let's go ahead and let's watch this again. Now here, they're just breathing in and out, okay? You can see a couple of things from the swallow previously. I have a little tiny trace amount of blue liquid located in the piriform sinus and just trace upper esophageal sphincter. Normal, right? So what's going to happen though is watch as my patient collects the bolus just above the epiglottis within the vallecular space. They've learned a little trick. Now, the trick they've learned is that their epiglottis does not completely invert. Therefore, it does not give this beautiful closure of the laryngeal vestibule. But they do have a relatively functional swallow. And what makes that functional? Why would I suggest that this is a functional swallow? Well, this is a patient who has been through radiation and chemotherapy. This is a patient who is 3 months post-radiation and chemotherapy. They've had their PET scan. It is clear. They are ideally looking to return to swallowing. Now, for me, the inside of the pharynx in terms of edema actually looks fantastic because I can see my laryngeal vestibule, I can see my structures, I can see my vocal cords. Also, my posterior pharyngeal wall, you can see, isn't screaming at me to where my epiglottis does have some room, some movement. And so what I'm looking for here is when my patient swallows, is it functional? The answer is yes, absolutely. So let's watch and see. Again, as the patient's going to swallow, I want you to watch a couple of things. First, they complete what we would call multiple swallows, which is 2 swallows in the speech pathology world. I'm not too concerned about that, okay? The reason they're having to do that is because they're having to push the liquid down through the pharynx again, right? So as this patient right here goes to swallow, we're getting that shortened whiteout period, right, for our fees. And that whiteout period, we get a second little swallow there. And then we're trying to sneak a peek in here into our vocal cord region. Now, I wish I had in this clip gotten a little bit closer, but what I'm looking for is any kind of gross aspiration, et cetera. Now, this patient swallow, to me, I was stoked. There's not only is there not significant aspiration risk at this time, but the one other thing is the residue within the pharynx is minimal across liquid trials. So that's very important for us as speech pathologists to consider. Residue following treatment of head and neck cancer is one of our greatest barriers in allowing our patient's swallow function to return to some normalcy. They have a significant amount of difficulty, oftentimes pushing the bolus through the pharynx. So when I complete my fibroendoscopic swallowing studies, I'm looking for residue as one of my key factors. Now, we do love Dr. Curtis's VASIS scale. We utilize that here with our scoring. So it's very important that you are also knowing what's the timing post-treatment for this patient, because what do we know about our head and neck cancer patients? They are going to change. Radiation fibrosis syndrome is going to set in and things are going to change. So it's very, very important that we keep our timing here, because these patients, we always say, are with us for life. Maybe they take, a 3-month break from us and we monitor them in 3 to 6 months, but there will be muscular changes. There will be likely lymphatic changes or lymphostatic fibrosis changes. So we're monitoring the functionality of the swallow and we're compensating as their body changes. I hope you enjoyed this, and I hope it helps you in moving your patient to that next step. Remember, we are always trying to keep them swallowing. That's the most important thing. Have a wonderful rest of your day.